Diabetes mellitus management, oral drugs. Introduction. Effectively managing diabetes mellitus involves a diverse array of oral drugs, each with distinct mechanisms and considerations. From the well-known biguanides like metformin to the nuanced actions of DPP-4 inhibitors, these medications play pivotal roles in addressing the complex dynamics of glucose regulation. This overview delves into the mechanisms and adverse effects of various oral drugs, providing insights into the intricacies of diabetes management. Biguanides, such as metformin, operate by inhibiting hepatic gluconeogenesis and the action of glucagon through the inhibition of MGPD. They enhance glycolysis and boost peripheral glucose uptake by increasing insulin sensitivity. However, these medications may come with adverse effects, including gastrointestinal upset, lactic acidosis, to be used cautiously in renal insufficiency, and a potential deficiency in B12. Notably, they often promote weight loss, which is a desired outcome for many individuals. Sulfonylureas are categorized into two generations. The first generation includes chloropropamide and tolbutamide, while the second generation consists of glypyride, glipizide, and glyburide. Meglitinides, on the other hand, include nataglinide and repaglinide. The mechanism of action for both sulfonylureas and meglitinides involves the closure of potassium channels in the pancreatic beta cell membrane, leading to cell depolarization. This, in turn, results in the release of insulin through increased influx of calcium. When it comes to adverse effects, both sulfonylureas and meglitinides share the risk of hypoglycemia, particularly elevated risk in cases of renal failure, along with weight gain. First-generation sulfonylureas additionally exhibit a disulfiram-like reaction as an adverse effect, while second-generation sulfonylureas are associated specifically with hypoglycemia. DPP-4 inhibitors, including linagliptin, saxagliptin, and sitagliptin, work by inhibiting the dipeptidyl peptidase 4, DPP-4, enzyme. Their mechanism involves the inhibition of the DPP-4 enzyme, which typically deactivates GLP-1. By doing so, DPP-4 inhibitors prevent the degradation of GLP-1, leading to an increase in its activity. This increase in GLP-1 activity can effectively regulate blood sugar levels in individuals with diabetes. Additionally, DPP-4 inhibitors have other effects such as decreasing glucagon release, reducing gastric emptying, increasing glucose-dependent insulin release, and promoting satiety. In terms of adverse effects, individuals taking DPP-4 inhibitors may experience mild urinary or respiratory infections. Notably, these inhibitors are considered weight neutral, meaning they do not cause significant changes in body weight. This characteristic can be advantageous for individuals managing diabetes, as it eliminates concerns about substantial weight changes associated with some other diabetes medications. Glitazones and thiazolidinediones refer to the same class of medications used in the treatment of type 2 diabetes. These terms are often used interchangeably. Glitazones or thiazolidinediones, such as pioglitazone and rosiglitazone, operate by activating PPAR-gamma, a nuclear receptor. This activation results in heightened insulin sensitivity and elevated levels of adiponectin, a regulator of glucose metabolism and fatty acid storage. However, the use of these glitazones or thiazolidinediones medications is associated with adverse effects, including weight gain, edema, heart failure, and an increased risk of fractures. Additionally, it's important to note that glitazones have a delayed onset of action, taking several weeks to exert their full therapeutic effects. Sodium glucose cotransporter 2, SGLT2, inhibitors, such as canagliflozin, dapagliflozin, and empagliflozin, operate by blocking the reabsorption of glucose in the proximal convoluted tubule. These sodium glucose cotransporter 2 inhibitors come with various adverse effects, including glucosuria, urinary tract infections, UTIs, vaginal yeast infections, hyperkalemia, dehydration, potentially leading to orthostatic hypotension, and weight loss. It is important to note that these medications are not recommended if kidney function is impaired, as their efficacy decreases with a decline in glomerular filtration rate, GFR. Alpha-glucosidase inhibitors, such as acarbose and miglitol, operate by inhibiting intestinal brush border alpha-glucosidases. This inhibition leads to the delayed hydrolysis of carbohydrates and absorption of glucose, effectively decreasing postprandial hyperglycemia. However, alpha-glucosidase inhibitors may come with adverse effects, with gastrointestinal upset being a common occurrence. It's important to note that these alpha-glucosidase inhibitor medications are not recommended for individuals with impaired kidney function. Conclusion. In conclusion, the diverse classes of oral drugs for diabetes mellitus offer a spectrum of options for tailored patient care. While biguanides contribute to weight loss and sulfonylureas stimulate insulin release, DPP-4 inhibitors modulate GLP-1 activity without impacting body weight significantly. Glitazones, with their PPAR-gamma activation, and SGLT2 inhibitors, blocking glucose reabsorption, present additional strategies. Understanding the mechanisms and potential side effects of these medications allows healthcare providers to make informed decisions, optimizing diabetes management for improved patient outcomes.